Good afternoon for those in the African region, and good morning to those who may be in other regions of the world. It is my pleasure this afternoon to share on HIV prevention, and basically we'll dwell on the innovative research and programs that were shared at IAS 2019. I'm now trying to move to the next slide. Oops, I'm moving faster, let's see. And again, I'll start by also thanking the IAS Educational Fund and the NAC for organizing this innovative webinar and an opportunity basically for us to share together. And that's the title of our presentation. So trying to move to the next slide. All right, yes, good. So the entry point for HIV prevention is HIV testing, because it's only when people know that they are HIV negative that they can uptake HIV prevention. And if they're not HIV negative, then they can move to the other arm, which is HIV treatment. So there's been a lot of challenges in reaching the untested. And we learned a lot from Mwango and the team on how to reach the unreachable in Zambia. And they used a two-pronged approach. One is social network testing strategy, where high-risk individuals are recruited, tested, and those positive are subsequently elicited for contacts. The other strategy is partner notification services, where partners of HIV diagnosed are offered testing and partner notification. So what we had and what we learned is co-implementing index testing and social networking strategy leads to high yields of positive among hard-to-reach population. Overall, about at 7%, and specifically 41% of men and 32% of adolescents and 8% of children. And there was a high acceptance of 89% of partner notification among those diagnosed with HIV, with 1.8 contacts elicited per person. 77% of contacts reached and tested, and 37% diagnosed with HIV, with 84 being linked to ART. So I think there's a learning point here of combining those both partner notification and social networking strategy. I think some of the countries could borrow such a strategy. Then one of the biggest challenges, and I know many of us in Africa can resonate with this or can identify with this, is the issue of engaging men in HIV testing and care. Men in lower and middle income settings are less likely to be engaged in the continuum of care, leading to late presentation, high mortality, and onward transmission. Engaging men is a priority in order to achieve the 90-90-90 targets, and even these targets have now changed to 95-95 targets. How best to reach men requires further implementation research. HIV self-testing is one route to promote testing among men that could be tested. And this study specifically in South Africa is an self-testing implementation study, provided a choice of oral or blood-based testing to men in rural peri-urban KwaZulu-Natal using mobile vans, workplace distribution, social and sporting events, and index partner distribution. After receiving self-test, testers received an SMS reminder after 2 weeks, and if no result was reported, a follow-up call after 2 months. Close to 4,500 kits were distributed, 92% to men, and 93% of the men said testing was easy, and there was a slight preference to blood-based self-tests. 73% of results known from the kits they were able to know about 73% of the results from the kits that were taken away, and 81% of those who tested positive were linked to care, and 73% started ART, and much higher rate of positivity among those who used the kits at the distribution site, which was 11%, compared to those who took the self-test kits away. I think HIV, what we learned from this project is that HIV self-testing overcomes barriers to testing, but not barriers to linkage. So what did we learn also about peer distribution? Peer outreach has a potential to reach key populations who may not be in touch with facility-based services. Peer outreach is being used to reach key populations. Female sex workers, men who have sex with men, transgender people, and people who inject drugs as part of USAID PEPFAR linkages project in Burundi. 2,321 kits were distributed from December 2018 to March 2019 with very high positivity rates. 14.3% among female sex workers, 13.4% among men who have sex with men. Self-testing accounted for approximately 1 in 5 diagnoses among female sex workers and 1 in 3 diagnoses among those men who have sex with men. And then there was very high linkage and ALT initiation among female sex workers, about 98%, but lower among men who have sex with men, about 85%. There was challenges in delay between positive HIV self-test result and confirmatory result at facilities due to transport problems or discomfort in visiting facilities. And so there is a need to look for solutions, and that's what the project recommended around transport reimbursement for those who present at confirmatory testing and the peer educators. And more widespread implementation of HIV self-testing with high-risk population could accelerate towards the 95 goals. So I think this again confirms that there is real value of using this mechanism of peer distribution of HIV self-test kits. Now let's change gears a bit to oral PrEP, which many of us in sub-Saharan Africa are familiar with because it's being implemented, and especially in Kenya, I think we are doing a good job in implementing oral PrEP. And we learned quite a bit from other countries also. And one of the studies I'll start with is called PrEVNIL study, which is a prospective cohort of men who have sex with men accessing PrEP in Paris region. And the prospective cohort is a demonstration project that aims to reduce new HIV diagnosis among men who have sex with men in Paris region by 15% in 2020 compared to 2016. Participants opted either for daily or on-demand PrEP at entry into the cohort. Remember, on-demand PrEP is the PrEP you take before a sexual encounter and follow-up. So usually works out to about 4 doses per week. 15% opted to change their dosing pattern. 49.2% opted for on-demand dosing. Balance between on-demand and daily dosing was maintained through follow-up period. A higher proportion of sex acts on the on-demand were not covered by PrEP at 17.8 than in daily arm, that's 2.7. Condom use was marginally higher on the on-demand arm. No differences in incidence between the two dosing regimens. 2 infections, both in the men who had discontinued PrEP at 7 and 10 weeks prior to infection. So the 2 infections were among those who had discontinued PrEP. Note that incidence is expressed per 100 person years. HIV is there was high incidence in viral hepatitis and bacterial STIs, and a substantial increase in incidence per year. But what I would want to say about this study, the on-demand PrEP has only been shown to work for MSMs. So as we move as we discuss this, that's the only population that currently can use on-demand PrEP. Then there's the big question which Connie Kellam discussed at IAS. This is the issue of sexually transmitted infections in the era of PrEP. And there's a big question out there: is PrEP associated with higher STIs? I think the jury is still out on this, because we know that even these higher rates of STIs that are being observed also currently among PrEP users were even observed before PrEP use. And the data on risk compensation is inconsistent. So when you put people on PrEP, there's a lot of testing. So we don't know whether it is the testing or an actual increase. So most studies will shed light on this. And but what we are seeing, and what is most important, is that there is a high prevalence of STIs among PrEP users, and that's why we need to move beyond syndromic management. There is need, I know, especially in Kenya and sub-Saharan countries, about the challenge of STI testing, where we have to send things to samples for testing, and we have to wait sometimes for days or weeks. So there is need for point of care. We need more sensitive STI diagnostic kits. We need to integrate STI testing into PrEP delivery. And more importantly, there is need to also have and start thinking about STI vaccine, especially for bacterial STIs. I know most of the countries have seen gonococcal resistance, but we also seeing a lot of high prevalence of chlamydia, even in our own cohorts, because I also do PrEP implementation research. Then moving now to programs. I'll share about this program that was designed in New York, and is a peer-developed online social network intervention that was highly feasible, acceptable, and efficient in engaging target audience. And I think that's the learning point, that this is a model that could also be used. And the ePrep intervention model may have utility for incorporation into program to enhance PrEP uptake and persistence and engage on other health issues. A more intensive and a fully powered campaign with longer follow-up is warranted, and also warranted in our own regions. What about integration? I think for those of us who have attended conferences in the last less than a year since the ECHO results were presented, we've had a lot around integration. There is now need for sexual and reproductive health integration. Though this campaign has been there for more than 20 years, but now there's a lot of talk around that, or close even to 30 years. And ECHO study is the one that has brought this discussion. But what was the ECHO study? ECHO study was a multi-center, open-label, randomized clinical trial comparing HIV incidence and contraceptive benefits in women using one of the 3 highly effective licensed contraceptive products. That is the IM, DMPA, a copper IUD, and a levonorgestrel implant. The primary objective was to compare HIV incidence among women compared to randomized to these 3 contraceptive methods, and secondary outcomes included pregnancy by contraceptive method and adverse events. The overall new HIV infection rates was 3.8% per year, and no difference in HIV incidence was observed by assigned contraceptive method. And this has been a question that has been discussed over many years, and I know most of us already on this webinar know about these results. And the primary data were presented were published in Lancet 2019. Another noteworthy point is that pregnancy rates were low in all the 3 groups, and with most pregnancies occurring among those who had discontinued the randomized methods. And these results underscore the need to continue providing these methods, and that these methods are efficacious and safe. But what was also observed, and why we are presenting this rates today, is that there was a very high STI prevalence and incidence in ECHO, and also a very high HIV infection. So what this calls for is a need to integrate both HIV prevention and pregnancy prevention, especially among young women. And I think there was also a study very closely related to this that was also discussed, which is the POWER study that was also conducted in a site in Kisumu, and which showed that PrEP and contraceptive correlated very well in this population, and that adolescent girls and young women who are using contraception were significantly more likely to initiate PrEP on the same day compared to those who are not using contraception. So what this is telling us is that family planning settings could be opportunities to initiate PrEP, and vice versa. If you have a PrEP setting, could be an opportunity also to integrate PrEP. And that the high quality contraceptive services then could be delivered in these settings. So the key point, this was a good discussion that was held at IAS, and a take-home message. Then, as I said, Kenya, we are implementing PrEP. Currently, we have over 60,000, close to 60,000 people already initiating PrEP, who have already reported initiating PrEP, and about 30,000 current users. But there was a qualitative study that was presented on this, which explored the barriers to uptake. Because 60,000 may sound a big number, but looking at probably the people at risk, this may not be such a high number. As I imagine it will be much more. And the barriers of uptake and continuation identified among young people in this study was stigma that related to the product. Then stigma, which was stigma was repeated as quite a barrier to uptake and continuation. And so PrEP delivery programs should prioritize interventions to address stigma at all levels, including sensitivity training for providers and intensify awareness to populations and communities, because as people become more aware, then you reduce the stigma. And this study also highlights the importance of qualitative research and acceptability of new prevention methods and barriers to uptake and use. So as we are implementing this, there's need for qualitative research. Now we'll change gears a bit and talk about the dapivirine ring, and I should add dapivirine vaginal ring. The dapivirine vaginal ring is being tested in 2 studies, and these studies were phase 3, but now and then the phase 3 studies then moved to the open label. And the 2 phase 3 clinical trials, one was MTN 020, which is known as Aspire, and IPM 027, that's the ring study, that showed that a monthly dapivirine ring was well tolerated and reduced HIV incidence by approximately 30% compared to the placebo. Women enrolled in MTN 020 or Aspire were offered an opportunity to continue using the dapivirine ring in an open label extension study known as HOPE. The study was designed to assess adherence and safety of a 12-month follow-up, and first they would come monthly for 3 months and then quarterly thereafter. Close to 1,700 women were screened and 1,456 enrolled, and this study was carried out in 4 countries, that is Malawi, South Africa, Uganda, and Zimbabwe. And the median age of the women who came for the open label was 31 years. 47% were married, 43 had used a condom in the last sexual encounter, and participants had a choice to accept a new ring at each follow-up visit. 73% chose to accept the prevention method at these follow-up visits, showing good acceptability of the ring. There was high persistence in this open label study. A total of 35 new HIV infections occurred, translating to an incidence of 2.7 per 100 person years. However, it's noteworthy that this incidence was 39% lower than what was observed in the placebo arm of the Aspire study, which was 4.4% per 100 person years. The results, along with those of the second open label study, known as DREAM, which were presented at the South African AIDS conference in 2019, suggest that adherence to and HIV risk reduction effectiveness of the dapivirine ring when used in an open label setting is high, making the dapivirine ring potential HIV prevention option for women. So again, this is a new HIV prevention method that could be added to the prevention toolbox. Then we heard a lot about the new products in the pipeline. And I'll start by talking about one of the products that's in the pipeline that is an oral product, very, very similar to the PrEP that we know. And the PrEP that we know is mainly a TDF-FTC. But now we have TAF-FTC, which is tenofovir alfenamide with amitriptyline, which is approved for treatment of HIV as Descovy. an an FDA advisory panel voted to recommend approval of Descovy for PrEP use in men who have sex with men, transgender women, but not in cisgender women. That was done, and many of us may have seen this. This was done in August 2019. So in our setting, then those are currently the populations who could use Descovy as a HIV, as PrEP. There was a trial known as Discover, which randomized and compared Truvada, which has been used a lot in PrEP, that is TDF-FTC, compared to TAF-FTC Descovy for HIV infection. Investigators examined sexual behavior, STI incidence, adherence, and PK to identify any differences between FTAF and FTDF, which could explain the fewer infections in the FTAF arm. There was no difference observed in sexual behavior or adherence between the two arms. But what was most important to observe is that there's faster achievement of optimal drug concentration in the TAF-FTC arm. And TAF delivers 4 to 7-fold higher levels of TDF-DP to PBMCs. In Discover, we fostered the state of TFP, that is tenofovir diphosphate levels in PBMCs, were 6.3-fold higher with FTAF than TDF. So there is very high PK levels when you use FTAF, which could explain the higher efficacy. Then we also know that there are trials that are happening on the long-acting injectable antiretrovirus, and this specifically is cabotegravir, which is an investigational integrase inhibitor developed by VivChem. Injectable cabotegravir and rilpivirine is being developed by Viv Healthcare as therapeutic and has been submitted for marketing authorization in the United States and European Union. Long-acting cabotegravir is also being evaluated as a HIV prevention, as an injectable product in HIV prevention, in HIV prevention trials network studies. And actually we have a site in Kisumu, Kenya, and many other sites in sub-Saharan Africa. Specifically, the biggest concern with the injectable has been the subtherapeutic tail, which is something that's being discussed, was initially shared in R4P 2018, and that shows that there's still drug that is there, what they call lower limit quantification, about up to 42 weeks in men and up to 66 weeks in women. So that's the big thing when you think about injectable antiretrovirus for PrEP, but discussion will happen to see how that can be addressed, whether people would go on orals during that period. Probably for those who did not attend or would not follow IAS 2019, there was, this is the first time that a phase 2A of an implant that could be used for HIV therapeutic and prevention, known as Islatravir, formerly MK8591, were presented. And this implant is placed subdermally in upper arm of the non-dominant arm, just as we do for contraceptive implants. And for this trial, it was tested for 12 weeks, followed by 4 weeks post-removal observation. Safety was demonstrated, and the only safety concerns were mild to moderate implant site hematoma, pain, and tenderness after implantation. Just the same thing that we see with contraceptive implants. Both implants, they were trying two implants, the 54 and 62 milligrams had concentrations above PK threshold at 12 weeks. The 62 milligram implant will continue to release through 52 weeks, and 62 milligram implant is projected to remain above threshold of 0.05 millimoles at 12 months and likely several months beyond. So this is quite important because it also says it could also go up to 16 months. So there is a potential product here, which could be an implant, which could address those who have adherence concerns, because this implant then could go on for longer periods. What about antibodies? We've heard a lot about antibodies in the AMP trials that have been presented in all other, the recent HIV conferences. But what was new in this conference was about the next generation products, the mononuclear antibodies targeting multiple sites. And this one of them was VLCO7, and which had 5 to 8-fold increased potency in vitro compared to the current one that's being tested in clinical trials, which is VLC01. And then the second one was the tri-specific antibodies, which is combining multiple broadly acting neutralizing antibodies. And again, and then is able, which improves efficacy and simplifies prevention and treatment regimen. And is something else that was presented. And so there's a lot happening in the field of broadly neutralizing antibodies, both for treatment and prevention. Again, another space to watch. So as I come to the end, is to mention that the prevention toolbox is expanding. There was a lot of breaking science presented at IAS, and I believe we'll have more breaking science in AIDS 2020, so stay tuned. So I'll come and visit. But also, as we move on, is also to credit that this information is from the toolboxes. It's not from this information is freely available for IAS members. You just need to go to the space and see the toolkits, and you'll be able to see much more. Because what I've presented is only a snapshot of the HIV prevention science that was presented at AIDS IAS 2019. Thank you.